All right, guys, welcome back. I hope you guys are still with me. I'm excited to be with you again today for acute gas embolism. All right, so we're going to talk about that. You guys have already done how to read dive tables. You guys have already talked about decompression sickness and how a bubble is formed. And like I said, in this respect, arterial gas embolism is the most dangerous indication that you will be subjecting yourself to as a tender, but also your patients, and it is the most life-threatening issue that a diver is going to experience, because there's obviously other indications that are going to be deleterious to your patient clinically, potentially. But this one for diving is extremely important. So looking at arterial gas embolism, right? When you're underwater, the different environments cause different risk to your body, right? And pressure changes on a submerged body can cause issue. And obviously when you're breathing compressed gas and you come up too fast, you could have a arterial gas embolism. Now, the number one cause of arterial gas embolism is an overexpansion injury of some kind, meaning they held their breath. So granted, in this lecture, most of our population that we talk about will still be an injured diver. Coming up too fast, maybe they were unconscious, hit their head, got narked and came to the surface too fast, whatever the case may be. That's probably the primary cause, but also submerged vehicle accidents, for example. Gas pockets, when they're welding underneath, they could cause a gas entrapment and then have a small explosion and it cause them to go up to the surface, for example, or a rapid change in a depth, for example. So there are other things. And then there's iatrogenic effects, or places that we actually do that in terms of head and neck surgeries and different procedures like that, which we'll talk about all those kind of things. So the arterial gas embolism, these fast facts, all right? So here's things you need to know. First, air embolisms are the most often formed by scuba diving, all right? That's our number one cause, is scuba diving, right? That's when they're most often occurred. The big thing is that air bubbles on the venous side are not as severe. We've talked about that with decompression sickness, right? The arterial side is what causes the most danger, because why? They can go to your brain, cause a stroke, or go to your heart, cause a myocardial infarction or a heart attack, right? So, there it is. Arterial gas embolism can cause strokes, right? Only about 3 milliliters of air injected into that cerebral vasculature, right, into the cerebral circulation can cause death. That's not a lot, right? So it's extremely, extremely dangerous, and that's why we have to act fast. We got to work fast to try to save our patients. And the only way we can fix these patients is with hyperbaric medicine. The only way you can reduce a bubble of gas size of any kind inside the body is with pressure under a hyperbaric chamber, right? Now, some medical procedures can cause air embolisms, head and neck surgeries, venous catheterizations, jugular venous, indwelling lines, for example, right? Now, it's an estimated 57% of orthopedic surgeries produce some sort of air embolisms. Symptoms of air embolism can be caused by joint aches, feelings of stress, chest pains, tremors. All right. Now again, the only way you can treat a arterial gas embolism is by a hyperbaric chamber, so it's extremely, extremely critical. And so if you're involved in thoracic surgery, again, even though these are rare, you should be able to at least know where you're going to be treating these patients if something were to happen, because not every place has a multi-place chamber that could treat a gas embolism if it was caused by a medical procedure, for example, because you have to go to 6 ATA. So you must at least think about these things if your programs are engaged in this and you have to actually support these type of procedures. So gas embolism location. Remember again, a venous embolism is not as serious as an arterial one. But again, the most severe case of any sort of embolism of any kind is a cerebral one, right? Because they all have potential. Even though I say, well, don't worry about your venous ones, they'll get filtered out. Yes, that's true, but they all have the potential to cause significant damage to organs and systems if they're left untreated or unchecked. So you must make sure that you're being vigilant there. And again, like I said, have the technology to take care of them. So this is a great slide of the old school from actually Dr. Eric Kinwall of the Navy Yard, where they actually did submersible training with the submarines. So this is the tube where basically they would flood it, and these autonauts or these aquanauts would come out, and they would ascend to the surface. And here's a picture of that. And so a lot of these cases where they were practicing depth resurfacing procedures, they would have a lot of arterial gas embolisms and a lot of injuries there. So arterial gas embolism causes, like I said, Not just dive accidents or scuba diving, which is your big mainstay, right? But a big one is head and neck surgery. Renal dialysis, for example. Heart and lung machines, overexpansion injuries, especially the old ones like the iron lungs and things like that. These things would cause a lot more issues. Cardiac catheterizations. Vaginal insufflations or C-sections, for example. That's when, or other sort of intra-abdominal process where they fill CO2, for example, and expand the belly, for example. So these things can still cause issue and at least need to be made aware of. So again, diving or overexpansion injury, meaning breath hold diving or coming up from a submerged vehicle, for example, these are going to be the most common cause of death among divers. You can also have it with some breath hold diving, for example, like if they were breath hold divers and you were snorkeling, for example, you did a breath hold dive and you went down and breathed off somebody's regulator, but you were untrained as a scuba diver. So you went down, you took a breath, you came back up, you didn't let your breath out of your lungs, you have an overexpansion injury. So these are real cases that can happen. But these other iatrogenic causes are so forth. The big ones are going to be hemodialysis, IV drips, right? These are pretty rare. All right, I don't want to have anybody worried out there saying, well, I've done this for 50 years and never had one. That's absolutely right, because like we talked about, the lung filtration system is extremely, extremely sophisticated. And most of the time, these IVs are not going to cause the issue. Now, of course, the laparotomies and things like that we talked about, open heart surgeries, lung biopsies, when you remove a section of the lungs, radiologic procedures where they're injecting dyes, things like that, childbirth in C-sections and things like that, and then ERCPs is another big one that can cause iatrogenic gas emboli. So looking at head and neck surgery, there's really no accurate figures knowing on what the prevalence of air embolism due to the surgical procedure is, right? But some estimates are anything from 10% to 80% of neurosurgeries and can have some sort of air embolism. Now that would make sense when you're looking at craniotomies, plates, things like that, and up to almost 60% in terms of your orthopedic surgeries, right? When you're having different joints and things like that. Now, again, most of these are mild. Nobody even has to even talk about them. But the big thing I want you to know for academic purposes, and occasionally can sprout up on exams, depending on how far you take this for whatever, is head and neck region is extremely important to talk about because the pressure is much less than atmospheric pressure when injuries occur at these sites, right? And so because you have head and neck, because you've got a lower pressure and a higher pressure on the outside, so your atmospheric pressure is higher, you have a lower pressure of the head and neck, it will accept air. Right? It will accept air, and so it will create an embolism. And so that is where, if you're looking at, if I gave you a test question and said, what's the most common iatrogenic cause of arterial gas embolism, your answer would be head and neck surgeries, head and neck procedures or injuries, for example. So it is important to note. Going back to diving, when you look at symptoms of an air embolism or gas embolism after diving, is you've got a couple different things here. One is going to still be a lot of like your DCS that we talked about, right? Joint and muscle pain. But a big one here is going to be a lot more vital instability. You're going to have a lot more low blood pressure, a lot more tachycardia, and those you'll be able to see in your vital signs, for example. And thus, then you've got dizziness, you got an irregular heartbeat, right? Because obviously, when air that gets into the heart that's not supposed to be there, it's just like your sucker in the pool, right? When it gets out of the water and accepts air, that pump stops pumping, and that can cause an arrhythmia and death. So chest pain, blurred vision, strong feelings of impending doom or anxiety or pressure of the chest, itchy skin, right? A blue tinge of the mouth, the tongue, which is obviously cyanosis, right? And you can have frothing or bloody coming out of the mouth, paralysis, and then of course loss of consciousness. And like I said before, remember, any scuba diver, this is one of the ones that when you have immediate, resurfacing and they pass out on the surface, you want to assume a arterial gas embolism immediately, and you want to get them on 100% oxygen right away into a hyperbaric chamber. So in this pictograph, this just shows you where a bubble, arterial gas embolism can get caught, and where's it going to go, right? So it comes from the systemic circulation, gets caught, and it's either going to go to the lungs. It's going to go to the lungs, it's going to go to either your brain or your heart, right? And so this is where you're going to have, obviously this is where it's in the heart, and it's going to cause some sort of, it's either going to be small enough to pass back through to the lungs and be exhaled, but if it's too big, it's going to get caught in the lungs, cause ischemia. And then, of course, the reason that you have an issue with a myocardial infarction is that bubble thus causes ischemia, causes hypoxia. And then when you have the myocytes start having cell death, and that causes the arrhythmia. Now, the arrhythmia is what obviously causes death, but unless you fix the clot, which in this case, the clot is a gas bubble, right? If you fix that clot, they would survive. And that's why you have to go in and immediately do stenting and things like that. But in this case, you have to have a hyperbaric chamber to reduce that size, and they'll do okay. Now in this case, this is an old pictograph from Dr. Kinwall again. Honored to be able to show some of his slides. Shows a normal alveoli, and then of course when you overexpand that, you take a breath, you have expanded alveoli, and then in this case, if you have an overexpansion, you hold your breath, or an increased introduction of air of some kind, or of a gas of some kind, that will then pop. You'll have a pneumothorax, and then those bubbles will either leave the lungs and then go into the cerebral vasculature and cause injury. So again, an arterial gas embolism is when air enters the left side of the vasculature, right? And it's most often caused by pulmonary barrier trauma, right? So these patients are going to be extremely critically ill. They need a multi-place chamber. They're most commonly going to be caused by barrier trauma, and they're going to need a chest tube as well, right? Now, the most dramatic effects on the brain is your cerebral arterial gas embolism, right? Now, in this, of course, your symptoms that will obviously be associated with where the bubble is in the brain, right? But you need to know that 4% of these result in immediate apnea and cardiac arrest. And those are a tough one to deal with. Your other common presentation, like I said, immediate loss of consciousness, seizures, disorientation, hemiplegia. It looks just like a stroke, right? And of course it is. It's an ischemic stroke. The difference is it's not hemorrhagic. It's caused by a bubble. It's caused by a gas introduction. All right, so again, arterial gas embolisms are much more serious. They may obviously prevent your oxygenated blood from reaching the target organ, causing ischemia, like I said, and we kind of talked about this before. When you have ischemia, you then can have cell death, and then that obviously, for an example here, would be a cardiac myocardial infarction or a heart attack, right? And of course, if it reaches the brain, then of course that's a cage, right? And that's going to be a stroke. And again, remember, only about 3 cc's of air of any kind can go into the cerebral system and cause a fatality, right? Now, only about 1 cc of air into the pulmonary vein can cause a cardiac arrest. So it doesn't take a lot. That's why it's so important if they move over to the arterial side, accidents can happen. So when you look at arterial gas embolism and scuba diving, as a general rule, again, any diver, I've said this before, that breathes gas under pressure at any depth, who surfaces that's immediately unconscious, that loses consciousness soon after, or any sort of neurologic symptom within about 10 minutes of surfacing, should be immediately brought to a hyperbaric chamber and should be considered AGE until proven otherwise, right? Guys, remember, decompression sickness is from 10 minutes to 48 hours. You guys remember that from the last lecture? This is extremely important. When you see immediate symptomatology, right, within 10 minutes or less, treat it as an arterial gas embolism. All right, it's very, very severe. We want to get them down there. And the big thing is, like I said, what you're doing is you want to get them into a hyperbaric chamber, and you want to use a treatment table 6A, because you want to crush that bubble, put it back into solution, get down to 6 atmospheres or 165 feet of seawater. You want to crush that bubble. Then you want to bring it back up to 60 feet, hyperoxygenate, combat the vascular damage that's been caused, the edema and the inflammation there, and hyperoxygenate the area, and hopefully have a good outcome for your patient. Here's an old example again from Kinwall of an example of a sad case of immediate arterial gas embolism pulled from the water there. Again, your initial treatment is oxygen first aid immediately. Put them on oxygen, put them on a non-rebreather mask, put them as much flow as you can, and get them oxygen. Because obviously these patients may not be breathing, right? So you wouldn't want a demand regulator. You'd obviously want a non-rebreather. It's the optimal way to give them. And then you want to transport them to a hyperbaric chamber immediately. But oxygen, 100% oxygen, it stops on gassing. You will start, at least helping off-gas some of that nitrogen. Again, you guys have seen this before, but here's your treatment table 6A. Remember, like I said, if I say arterial gas embolism, you must say treatment table 6A, right? That's for your tests. That's across the board. That's the one. And remember, a treatment table 6A can only be done in a multi-place chamber. You cannot do a 6A in a monoplace chamber. A monoplace chamber is only rated for 3 atmospheres. A multiplace chamber can be placed and rated at a 3 atmosphere or a 6 atmosphere, depending on its manufacturing qualities. But a monoplace cannot do this type of treatment, for those of you that are doing monoplace treatments. All right, so again, U.S. Navy Table 6A. This is going to be used for any neurosymptoms following a blowup greater than 60 feet, right? It is the treatment modality for arteriogasmism. Again, it is a modified table treatment 6, right? A Navy Table 6, okay? Where you start at 165, you crush those bubbles, and then you move up. And again, remember, this can bend your tender. We talked about this in our last lecture as well. It's extremely, extremely important. It's a very, very high degree of danger. But it can be done safely, of course, but it definitely holds a higher risk to your tenders as well. And of course, you have to extend it. You have a treatment table 4, which can be up to 40 hours long, as you guys have learned. Okay. So again, when you're looking at gas embolism, remember that other bubbles may pass through the ASD, for example, and you may have, just by having a cough or increased pulmonary pressure, like in a cough, you have your heart and brain as your most concerning targets, and those are the ones that need to be protected. So what is the benefit of hyperbaric medicine when you look at using a table 6A? Well, the big one is of course, like we talked about Boyle's law. When you increase the pressure, you crush that bubble. You put it back into solution with Henry's law, right? The deeper you go, you're forcing it back into solution. So what you're doing is you're moving that bubble to a smaller vessel and hopefully back into solution completely, right? You're diffusing the gas from bubbles. You're breathing oxygen. Now this is after you get after your compression at 165 feet. Now you're diffusing that with the use of oxygen. You're getting rid of the nitrogen, right? And you increase your oxygenation through plasma and collateral vessels by giving them oxygen, right, at 60 feet. It supersaturates the plasma where you don't even need your hemoglobin, which we've talked about in other courses and all my colleagues have. And so that is extremely important because you're helping to oxygenate what otherwise was devoid of oxygen, like in the case of a stroke or wherever else that may be, like the heart and the heart and the brain, for example. But when you have a bubble there that's caused ischemia, right, you have tissue damage, it can help reduce the damage of that by providing oxygen to the tissues and reducing oxygen free radical injury. All right. Air embolism can occur whenever the blood vessel is open to a pressure gradient and that favors entry of the gas, right? And like I said before, head and neck surgery is your most common cause of this because there's a lower pressure when the head and neck is opened compared to the outside environment, right? So it does not just happen when a blood vessel, So real quick for you guys to know is because the circular pressure in most arteries is greater than the atmosphere, right? It doesn't just because you cut yourself on your finger doesn't mean, oh no, air's going to get sucked in and I'm going to get an arteriogasmism. No, right? Because there's higher pressure in our veins and arteries, right? That's going to keep air out because high pressure, low pressure, right? So the pressure is going to go from a high pressure to a lower pressure, right? Well, in head and neck surgery or head and neck, that's where it's reversed. That's why it's dangerous. It's going to favor a gradient where high pressure to low pressure. In that case, when a head and neck is injured, that's where low pressure is here, atmosphere is higher, so it gets sucked in or brought in, and that's what happens. So it doesn't just happen just because you have a blood vessel injury, remember. That's why we don't get it when we cut our finger or whatnot, because the pressure gradient is higher in our bodies, or our blood pressure is higher than the atmospheric pressure. So in the veins above the heart, like I said, the head and neck, the pressure is less, right? And so therefore it's less than atmospheric pressure, and therefore the air may be let in. And that injury is how that it can occur. And that's why the surgeons of head and neck or cardiothoracic surgery must be extremely careful when they're operating on the brain and the head neurosurgeons, because when that's why the head of the bed is tilted, and then that's why they remove when they're doing central venous catheters or jugular and subclavian vein PICC lines, for example. Okay, so a large bubble of air after like certain trauma, chest trauma, for example, they can gain access to larger veins, may have a machine-like murmur. Like I said, it sounds like a PDA, right? That's what a machine-like murmur is, classically a PDA. But it's important to do the left lateral decubitus position. Trendelenburg, for those of you guys who are refreshing or new, they used to say put them in Trendelenburg. That's no longer evidence or guidelines. Now it's the left lateral decubitus position for the upstate side. So put them in the left lateral decube, and then we go from there. So the left lateral decubitus helps trap the air in the non-dependent segment of the right ventricle, where it's more likely to stay instead of move into the pulmonary artery and occlude it. Okay. So the left lateral decubitus also prevents air from passing through the potential PFO, which, like I said, again, occurs in 20% of the population, so 1 in 5. And then, of course, that will allow it to not cause embolization later, right, or causing stroke of the brain and so forth. So again, high percent of oxygen, 100% oxygen is recommended for both arterial gas embolism when you have venous gas embolism, when you have arterial gas embolism, or a cage, like cerebral gas embolism. All right, cerebral arterial gas embolism. So when you're looking at that, you still do your left lateral decubitus. That's your big takeaway, and you want to make sure that you give them as much oxygen as you possibly can. So again, the takeaway is, again, get them to a hyperbaric chamber. Treat them with 100% oxygen in the hyperbaric chamber. Treat them with 100% oxygen before you get to the chamber, right? Now, again, the earlier you get to these patients, the better they're going to do. Obviously, we know that because ischemia, right? Lack of oxygen is cell death. The sooner, just like CPR, the sooner we can reestablish circulation, the better the patient's going to do, because that's less apoptosis. Because it damages or reduces ATP, causing apoptosis, causing cell death, which we'll talk about in stroke and things like that a little bit later too. But again, remember, early treatment has the greatest benefit, but it can be effective up to 30 hours later, evidence shows. But again, you don't have, the window is still real tight. So the quickest thing is you can get them to a hyperbaric chamber as fast as possible, put them on oxygen as fast as possible, and get these guys treated. Thank you guys so much. We'll see you in the next lecture.